Welcome to the CodeCast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the 182nd episode of the CodeCast podcast. My name is Terry Fletcher. I hope everyone had a nice weekend and you're ready to embrace your work week today. Our topic today is something called the 21st Century Cures Act, or you've probably heard it as the Information Blocking Regulation. So this became effective last Monday, April 5th. I actually had a whopping 4-minute segment about it on the Talk 10 Tuesday with ICD-10 Monitor. So I wanted to expand on that on my podcast because it's important that you know what is necessary when a patient requests their records now and how you could get into monetary trouble, meaning having to pay a big fine if you're not careful and fulfill that request. So I really want to talk to you about it so you understand what it is and how to reference it and make sure you bring it to your provider's attention. But first, the CodeCast podcast is also brought to you today by JP Morgan Private Bank. Connect with over 200 years of experience, service, and stability. JP Morgan Securities, JP Morgan Chase Bank, privatebank.jpmorgan.com. Okay, so let's take a look at this Cures Act and what does that even mean? And I'm not saying CARES. Remember, that has to do with the public health emergency and everything. This is called the 21st Century Cures Act, C-U-R-E-S. Now, this act was actually signed into law in December 2016, and then we had the ONC then took it a step further. That's a branch of the HHS. That's the Office of National Coordination, IT, and they published the final rule in May 2020. The original compliance date was November 2020 last year, but of course with the pandemic, they pushed the compliance date to last Monday, and it's now in effect. So in a nutshell, what this is it's for providers to cease all efforts of information blocking with respect to their electronic records and to encourage and promote what they call interoperability and allow for communication and cooperation with third-party application program interfaces. So if a patient wants to get a download of, let's say, a test result and your office interfaces, let's say with Doxy, and they have that on their phone, and that's how they request it, then you actually have to provide that to the patient. You can't say just go to your patient portal. So what this information blocking is in this act, it's defined as any practice that is likely to interfere with, prevent, or materially discourage access, exchange, or use of electronic health information, and if conducted by a healthcare provider, such provider knows that the practice is unreasonable and knows that the practice is likely to be considered information blocking. So one thing I wanted to talk about that is obviously you're going to have providers saying, well, I didn't know it was, if they end up, doing something incorrect. But because it's now published and the act is now part of the rules and the regulations, now they feel that if it is unreasonable because it's your responsibility to be up on all of these regulations. I'm telling you, you might want to join my Medicare update this coming Thursday. So anyway, just because it's just so important to have all this information. So for entities such as health information networks or exchanges, they're actually going to have $1 million fine per occurrence if they don't give it to a patient. For healthcare providers, they haven't published the penalties yet, but I promise you it will be substantial because the settlements and awards that have been given when HIPAA gets involved, when the Office of Civil Rights gets involved, and they've basically pushed it to the ONC. They're like, look, we're tired of, patients filing a complaint and saying they can't get their records. And so in the past 5 years, and all these complaints and HIPAA violations for blocking access, there's been a lot of fines and legal settlements for patients. So just know you have to adhere to the rules. So the act does not require that providers, they actually call them actors, to have or use health IT certified under the ONC, but they are required to upgrade your health IT routinely, but we always do that because obviously things get slowed down and we have to upgrade our health IT and our electronic medical record system, and there we get automatic updates for that as well. But here's something within the Cures Act that I thought was kind of interesting and really thought-provoking, is that the healthcare provider definition is very broad. It does not adopt or use the HIPAA definition, which is a provider that submits claims electronically, but it uses the Public Health Service Act definition that includes all healthcare providers. This includes paper claims, cash-based, concierge medicine, hospital, physician clinics, dialysis centers, pharmacies, home health, etc. So that means everybody that's involved in healthcare. So the minimum amount of information, or what they call U.S. core data for interoperability. And interoperability basically means the concept of being able to mesh records together so that everybody doesn't have to go searching out records all over the place to find things. So interoperability means that it's all interactive, or the ability to be able to find it for one patient, almost like a one-stop shopping, but it's the ability to access for one patient is much easier. So here's what they talk about when it comes to the minimum amount of information, and they call it the U.S. core data, that's required to be available upon request. That's the biggest thing, is the patient requesting it. So medical records such as nursing home notes, RT, PT, OT, billing and payment records, insurance information, clinical laboratory test reports, image results and narratives, so any kind of comments that are made on those image results, wellness and disease management program information, and then any physician clinical case notes. Now, there's some exceptions to the portion of the clinical notes where the physician could block access, including psychotherapy notes or HIV testing results, basically any notes that in a physician's judgment could cause harm to an individual, such as information for civil, criminal, or administrative action. But if you block them for that reason, you have to make sure that you have documented that. So before I give you an example of information blocking, there are 3 things that I just want to make clear, because I think some people are kind of thinking that this new rule has changed certain things when it comes to rights. So information blocking does not create new rights to electronic health information or remove the protections regarding sharing EHI. HIPAA is still alive and well. Information blocking does not require providers to share any and all data with anyone that requests it or in any format. And information blocking really creates an enforcement mechanism, is what it is, to ensure that appropriate health information, electronic health information, that's the EHI, is shared or made available when authorized and appropriately requested by a patient or caregiver that is authorized to use it. So let's give an example of when this could be a problem. So let's say your IT staff, and for those of you who have small offices, that could be you, receives a request from a patient asking to use a third-party app to view their health data. The app was connected and validated by your practice earlier this year. Your organization also owns an online patient portal tied to your EMR that provides health information electronically. So without really reviewing the request, you just saw that the patient asked for their information, the IT staff, or you direct them to their patient portal. Well, this is a problem because the patient asked to use the third-party app. I mentioned Doxy before, and you basically sent the patient, to find or to use whatever was more convenient for you, not what they asked for. So this could be considered information blocking because your organization has the capability to meet the manner requested, but did not pushed out in an alternative manner. So that does violate content and manner exception. Now, let's say that there was an unlikely interference. So let's say this is something that wasn't interference. Let's say that your organization hasn't participated in the open notes, basically where your patient can access everything, yet on your patient portals. So while your patient portal can support posting clinical notes, your organization has chosen to configure the patient portal so that notes are not immediately visible to patients. So this is unlikely to be information blocking because there was no request by the patient. Remember, it's only information blocking if someone requests the information and you do not fulfill that authorized request. Let's be careful on that. So there's no requirement under the information blocking regulations that says you have to proactively make available any EHI to patients who have not requested it. So it doesn't require that. However, it does require that once the request to access, exchange, or use the electronic health information is made by a patient, they call them, or a provider that has asked for it, they must be responded to in a timely manner. And you cannot delay it for what they call unnecessary impediments, because that could implicate that you are violating the information blocking provision. And you have to be just really careful about this because it is It's becoming an issue, and there are patients that will, now that they know that there's a law out there, they will definitely file this. And so it's really important that you Google this information, check it out, make sure you look it up. It's 45 CFR, and I'm focusing on Part 171, but it's called the 21st Century Cures Act, and it became effective on April 5th. So just make sure you're looking into that. But the biggest thing I want you to ask your practice and, talk to your administrator is, how many outstanding requests for patient information do you currently have sitting in a pile somewhere? Do you have a log for these requests? Do you have a detailed exception for unfulfilled requests? And really, how are you going to handle these requests now that we actually have a specific rule on how you have to handle them? So you need to make sure that you have some kind of a compliance plan moving forward. Otherwise, this could definitely be an issue. So just wanted to bring that topic up to your attention, because it's going to be quite interesting once this all kind of comes into play and patients start to realize what they can access. Okay, so let's talk about our coding question today. And today I wanted to focus on an ICD-10 question that's come up a little bit pretty often for me, and it's on atherosclerosis, or atherosclerotic heart disease. And we kind of call it CAD, but that the old acronym doesn't really match sometimes. But here's two questions that I received recently. So, Terry, do I need to report more than one code if a patient has atherosclerotic heart disease of the native coronary artery along with angina? Well, the answer is no, because you need to look at the code selection starting at I-25 .11, and then there's going to be a 6-digit, but it starts with I-25.110, and that is with unstable angina 111, which is angina with documented spasm and so forth. So there's going to be a 6th digit on that, in that I-25.11, and then there's like a placeholder there to figure out your 6th digit based on the status of the angina. Now, always check your documentation. This is the one thing I just want to be clear about on atherosclerosis, because if your physician documented atherosclerosis of an autologous vein coronary artery bypass graft with unstable angina, then you're going to change to or look at the I-25.710 code, because now that's atherosclerosis of an autologous vein coronary bypass graft with unstable angina. So make sure you're looking in that area. And you could also have an I-25.7 and another code as well, another digits, because that's when you have a transplanted heart with angina. So there are some nuances when it comes to atherosclerosis, and you just want to make sure that you are looking in the right spot, because it doesn't just stop with the native artery or coronary artery. You have to look and see if there is other issues with that patient, if we're dealing with the possible transplanted heart, or we're dealing with a vein and a possible bypass graft. Okay, our coding question is brought to you today by Keck Medicine of USC. Over 500 nationally renowned doctors at a leading academic medical center, keeping you healthy, on track, and doing the things you love. The Keck Effect, keckmedicine.org. So I'm going to end my personal tidbit this week with actually a life hack, because it's been driving me crazy. So you know how we're all wiping down everything, and hopefully we're still doing that, washing our hands and making sure that our desks are super, clean and everything before we come back to work. Well, how many times do you come back to work and see dust or crumbs? I'm like, who is eating at my desk? Or we have it in our cars. You're thinking, I need to get my car detailed or whatever. Here's a little hack, and it's very inexpensive. It's $1.99. For those of you that are driven crazy by dust or crumbs or anything anywhere in little crevices, go get a compressed air can. It has that tiny little straw at the end, and it's called an electronic duster. It's called Dust Off. And it's amazing. It's for your car, your middle console, your computer keyboard, you name it. It is awesome. It also is fun to scare your cat if you want to. But all I'm saying is to take a look at that, and I think you'll find that, oh my gosh, where was this my whole life? So anyway, just a little life hack I thought I'd send your way if something's bothering you. But crumbs drive me crazy around my desk, or dust. So it never seems to go away, especially if you work near a window and you have people doing gardening out front. So anyway, just a little tidbit there. Hopefully this was information you needed this week, and that's it for me. So everyone, make it a great day, and I'll talk to you next week on the CodeCast podcast. Thanks for listening.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.